Hello, you're listening to the RxConnect Podcast. This podcast is brought to you by the pharmacy operations at the American Oncology Network. We are committed to delivering operational, clinical, and financial efficiencies based on the most sustainable model, reshaping the future of community oncology practice. I'm your host, Melody Chang, VP of Pharmacy Operations at the American Oncology Network. Today, we continue to delve into the critical issue of cancer drug shortages with a specific focus on navigating shortages in head and neck cancer treatment. To listen to the podcast and to read the transcript, please visit our website at www.aoncology.com. I'm delighted to introduce you two outstanding guest speakers. Dr. Chang Warsch, a medical oncologist at the Messino Cancer Centers in North Carolina. Dr. Warsch graduated from University of Miami Miller School of Medicine in 2010, and he joined Messino Cancer Center in 2017. He has a special interest in melanoma, lung cancer, and head and neck cancer. And my second guest is my esteemed colleague, Dr. Bradley Winegar. Dr. Winegar graduated from East Tennessee State University with a Doctor of Pharmacy degree. He then completed pharmacy practice and hematology oncology residency at the University of Louisville Hospital. He joined AON in 2021. He serves as the clinical pharmacist for the East region, covering Washington, D.C., Maryland, Virginia, North Carolina, South Carolina, Georgia, and Florida. Dr. Winegar is passionate about staying up to date with current medical literature and providing evidence-based care. Welcome, Dr. Warsch, and welcome, Brad.
Thank you.
Thank you.
As we continue our drug shortages series, in this episode, we want to focus on head and neck cancer. Dr. Warsch, could you please educate our audience about head and neck cancer, including what it is and its common clinical presentations?
Okay, thank you for having me. Yes, so head and neck cancer is sort of a blanket term for any cancers we think of that are in the oral cavity, oral pharynx, and down into the larynx. Usually they're squamous cell carcinomas, but depending on the original site of origin, we'll see different presentations based off of where the cancer is arising from. We'll see when patients have oral cavity cancers, for example, they could present with oral pain, non-healing ulcers, ill-fitting dentures, oral pain. These are things we look for oral cavity when the cancer could be coming from the tongue or the jaw. And then when we go down to the oropharynx, we think that's the base of the tongue and the tonsil in the more posterior part of the throat. Those people will have issues related to painful swallowing, coughing up blood, and like I said, swelling in the neck and the mouth. And we also see swelling in the neck when they present with lymph nodes. It's not uncommon for oropharynx cancers to have a silent primary, but a large lymph node in the neck as the first sign that there's a malignant process. And then when you go down to the larynx, that's right by the vocal cords. So people usually present with hoarseness or voice alterations, and that's usually the first sign that something is off in these presentations.
Sure. Thank you, Dr. Warsch. This is excellent. You have made a complex disease easy to understand. And I know many times patients may ask, why did I get this cancer? Could you please touch on some risk factors or known causes of head and neck cancer?
Oh, sure. Yeah, it's a very interesting topic. Historically, we would think that head and neck cancers are most of the time related to tobacco and alcohol use. You think of smokeless tobacco and oral cavity cancers, and then for larynx cancers, more cigarette smoking. And while that's certainly the case, what we've seen is a rise in HPV positive disease. And this is usually in younger, more healthy, more fit patients that have the malignancy that's related to a viral exposure that they may have gotten 20 or 30 years in the past. And these usually are diseases that present in the tonsil and the base of the tongue. We think a lot of the times these seem to be HPV positive, and we still treat them very similarly. We haven't adjusted our treatment approaches, but there's ongoing studies about perhaps de-escalating care in these types of diseases. But we do know that they have better outcomes, probably combination of having more sensitive disease, but also the performance status of these patients is generally a little more robust. And there's a hope that with the HPV vaccine that's used for cervical cancer is a primary indication, but it also is noted for the FDA to have a positive effect on the preventing head and neck cancers as well. So hopefully we'll see a decrease in the incidence of all of these malignancies with smoking cessation and vaccination.
Thank you so much. This is excellent. And when reading through the NCCN guidelines, and you kind of get a sense that a multidisciplinary approach is key to the treatment of many cancers, including the head and neck cancer. Can you describe the multidisciplinary team you work with in the treatment of these patients and why it is so important in this cancer type? Is there any tumor board where all these specialists that discuss the best course of actions for your patients?
That's a good question. Yeah, certainly. And in Asheville, we're very lucky that Asheville's not a large metropolis, but we have a lot of specialists in a lot of different fields of oncology. And here in Asheville, we have a weekly head and neck conference that's attended by myself as the medical oncologist, but we also have attendance by radiation oncologists who have specialty in head and neck cancer, as well as ENT surgeons. And on top of the surgeons, we're also joined by nurse navigators who help coordinate care for patients. And a lot of times, due to the nature of the disease and the toxicities, they'll also need help with other issues. So we will engage speech therapy, nutritionists, occupational therapies for lymphedema, as well as a dental care, palliative care, and social worker. So a lot of times at these meetings that we have once a week to sort of talk about the ongoing care of the patients, we're able to engage different specialties to optimize the care of the patient and lead to better outcomes.
Excellent, excellent. So now let's discuss the treatment of head and neck cancer and why the platinum shortages is so important so impactful for these patients. We know a recent survey by NCCN revealed that 93% of large cancer centers are experiencing a shortage of carboplatin, and 70% have reported a shortage of cisplatin. And I like to quote from the ASCO Drug Shortage Guide for head and neck cancer, which states platinum agents and cisplatin specifically play a major role for which there is no substitution in the treatment of head and neck cancer patients. This shows there's no easy workaround during the shortage. Can you tell us how the platinum shortage has affected your head and neck cancer patients?
Yeah, no, it's certainly been a challenge, and as you've noted, I mean, the two main platinum drugs we use in this space are carboplatin and cisplatin, and unfortunately, with the shortage of both of them, there's no easy answer. And like you noted, there's certain diseases where we do have alternatives, but especially in head and neck, given the sensitivity to this agent combined just with the overall aggressiveness of the disease, we do feel that there's oftentimes really no substitute for this agent. So to sort of best use the drug and optimize the supply, we have some of the recommendations are to focus the use of platinum in patients who are curative disease as opposed to more palliative, and overall to be a little more judicious in any situation where there's not a strong indication. In the head and neck cancer space, we try to avoid that. And some of those would be where you're dealing with maybe a cutaneous squamous cell carcinoma or a salivary gland cancer. That's the benefit of platinum, is not overwhelming. So the recommendation would be to maybe limit the drugs where there's limited clinical benefit. And that would include when we do adjuvant treatment, it's generally radiation after surgery. And when someone has positive margins or extranodal extension where the disease is spread out of the lymph node, we certainly add chemo to radiation. But unless these patients have very serious risk factors, try to do single agent radiation as much as possible.
Excellent. Thank you, Dr. Warsch. Certainly your expertise shined through in your responses. And have you had to use a different radiosensitizers during the chemoradiation treatment besides the platinum at any point?
Yeah, so there's a few options, and a lot of them do have platinum involved, but there's others that don't. The standard of care for chemoradiation for head and neck cancer is cisplatin, but the drugs with similar agents with their protocols with similar efficacy include a combination of carboplatin and 5-FU as well as carboplatin and Taxol, and we could use one of those two doublets along with radiation if there's no cisplatin available. But like you mentioned, if we're short on carboplatin as well, we run into the same issue. And there's the concerns about increased toxicity when you use a doublet with radiation. So we try to avoid that as much as possible. The other options that we have when there's no platin available, either cisplatin or carboplatin, is weekly cetuximab as well as weekly docetaxel. Docetaxel being cytotoxic chemotherapy, whereas cetuximab is a monoclonal antibody. And these agents are tolerated probably a little bit better than the doublets, but we do know from a study comparing cetuximab to cisplatin that the cetuximab was inferior to cisplatin in HPV positive oropharyngeal cancer. So you're dealing with, sometimes a situation where you have to make the best choice, even if it's not the optimal choice for that patient. And we do know that cetuximab and docetaxel given with radiation are superior to radiation alone. So when you're short resources and we don't have cisplatin or carboplatin, we do feel like there are other options. And other ways we could limit the use of platinum is when it's a potential resection. Sometimes we start with surgery, sometimes we start with chemoradiation, and if we know we don't have any platinum available, we could prioritize surgery, and oftentimes after surgery, patients might not need the cisplatin, so we could limit the use of platinum in that setting.
Thank you, Dr. Warsch, for sharing your extensive knowledge with us. Thank you. My next question is for Brad. As a pharmacist, we understand that regulations for shipping drugs across state lines in the United States can be complex and are subjected to both federal and state laws. In light of the recent drug shortages, Brad, could you share insights into the specific regulations and compliance requirements for shipping drugs across state lines? Additionally, how does our pharmacy operations ensure compliance while effectively addressing these shortages?
Yes, thank you for that excellent question, Melody. This has certainly been an eye-opening to me. So I always thought of us all as stewards of the supply chain, whether we are located in Arizona or North Carolina like me. So if a patient in one state needs a drug that is on shortage, then I thought we could ship that medication from one clinic in another state to the other patient. However, during these certain shortages, I came to realize that this can be more difficult than I imagined. Each state legislature, and more specifically, each state board of pharmacy, has rules and regulations on this state-to-state transfer. I won't get into the weeds here about the state-specific rules and regulations, but it's important for everyone to know that each state can be different. Where one state may allow the transfer, with appropriate documentation, of course, others may not. Some state boards of pharmacy heavily regulate transfer across state lines. And during these times of shortage, we have actually petitioned successfully for allowances of these transfers. But there can be, for lack of a better word, a lot of red tape in these times. One could say if a medication is legitimately approved by the FDA, why this red tape? I'm going to be optimistic here for a moment and say that there's an act called the Drug Supply Chain Security Act, or DSCSA for short. And the purpose of this is to have a more fully secure nation's drug supply, making it easier to detect and respond to suspect or illegitimate drugs. And this act makes it much easier to electronically track drugs, tracing them all the way back to their origin. So I'm hopeful that in the future, once this act is rolled out, that transfer across state lines will become more free. Last thing that I want to say is that we have some real experts on this topic on the pharmacy operations and procurement team, not to mention even the legal team that we work closely with. So any questions about the movement of medications across state lines, please reach out to us and we can provide assistance, as we are well versed in compliance requirements within each state. Thank you, Melody.
Excellent, excellent. Thank you, Brad, for providing this valuable insights. And I have another question for Dr. Warsch, if you don't mind. I just want to touch on the recurrent or metastatic disease and to see if a study like a Keynote 048 changes your practice. Can you remind us of what this study looks like? And when you are deciding what treatments to choose, I'm sure there are a lot of factors, but do you look at the PD-L1 CPS levels? And can you speak a little bit more to our audience?
Yeah, certainly. As you mentioned, the Keynote 048 study really was a game changer. It really changed the standard of care for recurrent or metastatic head and neck cancer. Prior to Keynote 048, the main regimen we used was seen based off of the EXTREME trial, which was a combination of cisplatin, 5-FU, and cetuximab. That regime was fairly effective, but also quite toxic. In the Keynote 048 study, there were 3 arms where they compared single-agent Keytruda to platinum 5-FU and Keytruda versus the standard platinum 5-FU cetuximab arm. And they also looked at different PD-L1 expression levels. But overall, I mean, the main thing that we were really interested in looking at was the combination of chemo plus IO versus chemo plus cetuximab. And in all comers, that had the study did show an improved overall survival, both in the short term from 13 to 11 months, as well as increasing the 4-year overall survival from 5 to 19%. As you could tell, though, the downside is both of these regimes do use platinum, so that speaks even more to the importance of platinum. And when we have this available, we do like to use it in this setting. They also, like I mentioned, looked at single-agent Keytruda, and there were some positive results when patients had a CPS score greater than 20. It did show that the Keytruda was effective as a single agent. However, in my patient population, we do get a little nervous doing single agent immunotherapy when patients have aggressive disease that might be growing pretty rapidly. So we do usually start with chemotherapy plus Keytruda in this setting. And then whether we do platinum plus 5-FU versus platinum plus Taxol sometimes is a little sort of more of a patient, or it's a physician's preference, but we have seen some good advances, and it's nice to have options to give patients once they're in a dire situation like this.
Thank you. Thank you so much. And Dr. Warsch, and this has really showcased how platinum shortages can impact the patient's cares. So before we wrap up, I want to ask Brad or Dr. Warsch, do you have any closing thoughts you would like to share with our audience?
Yeah, I can go first. And these shortages, of course, should never happen. But I will say that after this year of shortages and the profound impact that they have had on so many, I actually take heart that so many, just as we're doing here, are talking about the impact of these shortages on patients. I went to an oncology conference last week, and I've went to a lot of oncology conferences during my career, and I've never really saw drug shortage presentations. But at this conference, there were presentations, breakout sessions, and posters all discussing drug shortages. So I think this greater visibility about this terrible problem is a good thing, and we need to continue to shine the light on these shortages, as so many of our AON leadership team has. Thank you, Melody.
Thank you, Brad.
And I would agree. Yeah, sort of piggybacking on the point that Brad made is that we, as AON, as our clinical practice, and as physicians, we're continuing to focus on advocacy, talking to lawmakers both locally and nationally, and through organizations such as COA, which is the Community Oncology Alliance. And we found that a lot of the lawmakers really don't understand sort of the nitty-gritty that we might take for granted. So just by educating them, explaining the gravity of the situation, we're very hopeful that could help.
Thank you so much, both. Before we conclude today's podcast, I want to extend our heartfelt thanks to our esteemed speakers for sharing their valuable insights and expertise with us. Your contributions have enriched our discussions, and we're truly, truly grateful for your time and knowledge. And I'd like to thank our audience for listening. This podcast is brought to you by Pharmacy Operations at the American Oncology Network. And you can listen to all the podcast recordings on our website at www.aoncology.com. We hope you enjoyed this episode and look forward to seeing you at the next one. Thank you.